Hello, everyone, and welcome back to another episode of AdvoKAYte, Holding Healthcare Accountable. This is part 2 of my conversation with Dr. Robert Henderson. We were just getting to the good stuff when we ran out of time, so we decided to extend the conversation to another episode, but frankly, we could have extended it to another 10 episodes. Dr. Henderson is a wealth of knowledge, and I think you will find this riveting, why one man, one surgeon, decided that he had to do something to prevent Christopher Duntsch from hurting more people. So I hope you'll enjoy this episode with Dr. Robert Henderson. AdvoKAYte, Holding Healthcare Accountable. This podcast is my way of sharing what I've learned about the mistakes, the cover-ups, and the ways we can all protect ourselves. We're all in this together.
So I started thinking, well, it occurred to me, well, maybe he's an imposter. Maybe he has manipulated himself in this situation without ever having been formally trained. So on Monday, I started investigating, and I called these residency program and I called these fellowship program. And either immediately or within a few days, I was able to talk to that director and that mentor.
Two things are interesting to me about that. Number one, you said you started investigating. 99.9% of surgeons like you who would have been called in to fix somebody else's mess would have done their job and gone to the house. So I want to talk about why you couldn't and wouldn't leave it there. And I also want to talk about why your first step was to call the people who trained you. Okay, so it's kind of two questions in one, not really allowed in litigation, but we're not in the courtroom here.
Yeah.
So
yeah, exactly. And to be honest, I can't remember who I called first.
Mm-hmm.
I know I called the residency program before the fellowship, but on Monday I started saying, well, I mean, because of the history I already knew, where he'd killed one patient, made a quadriplegic out of another.
Mm-hmm.
And then I had heard a little something about some issues even before that. But I said, we got to get this guy stopped, number one. So I didn't really know who to call. I called the County Medical Society. They said, well, I don't know who to transfer you to. And I said, okay. Oh, but they did look him up, and he said, oh, he's not registered in the Dallas County Medical Society. And I could kind of hear the person on the other end of the phone let out a sigh of relief that he didn't have any more responsibility. So I said, okay, yeah, he's up in Plano, so maybe I need to call the Cullen County Medical Society. So I did that. Same response, don't know what to do, don't know what to do with this information, et cetera, et cetera. Why don't you call the Texas Medical Board? So I called the Texas Medical Board, and they said, okay, send in a complaint. We'll look at it within 30 days, and we'll call you back. I said, well, that doesn't help me. Mm-hmm. So I called the police. They didn't know what to do. They said, no, well, we've never dealt with something like this before. And it's true. They'd never dealt with anything like that before. Mm-hmm. And then I called the FBI and got the same response. So I said, well, this isn't going so well. And then I started the investigation with the residency program, so on and so forth. I actually sent a picture. There was a picture with his application to a Dallas Medical Center. And so I got a copy of that, and I sent it to the residency program and to the fellowship program. And they confirmed that was the person they had trained.
Because you thought this could not be a physician, much less a residency and fellowship trained spine surgeon that did this surgery. Either
No.
somebody's impersonating a spine surgeon or,
Yeah.
something.
But anyway, that blew that up. I mean, it did confirm that he was a physician. He was a licensed physician. He was a residency trained neurosurgeon. He was a fellowship trained spine surgeon.
Well, I know you wouldn't toot your own horn, as they say, but I guess I want to toot it for you, because when you say, I wrote this down, you said, we have to get this guy stopped. Well, really, it wasn't your job. It was the job of other people who came before you, during you, and after you. And this is why you'll always be my hero, is because you had the moral conviction to say, I'm going to make it my job, because I've always known you to be somebody who cares about patients. But I just wanted to be clear about that. When you were talking about, you started your investigation and all of that, and nobody knew what to do. There are others that have obligations to police doctors, and they didn't do their job. And so you picked up the mantle and did it. And really, it started with you and your courage. And so I want to call you out for that, for what you did.
Yeah, and I'd be remiss if I didn't mention Dr. Randy Kirby, too.
Yes.
Dr. Randall Kirby, he was extraordinarily helpful and a big, we just worked well together, but he initiated some of the interviews with the DA's office.
Yeah.
And that was very helpful.
And for every Dr. Henderson, Dr. Kirby, Dr. Lazar that was out there pushing the medical board, pushing hospitals, pushing to try to get him stopped, there were 100 others that sat on the sidelines. And this reminds me of the, see no evil, hear no evil, speak no evil.
It was interesting. My peers, I got confirmation by a good number of them. And then I got non-recognition by a significant number. And then I got criticism by a significant number. And it was interesting. I mean, some of those phone calls came from across the country. People from my past,
Mm-hmm.
or people, and I'm talking about physicians and surgeons, who had now risen to pretty important positions in some of the bigger organizations, saying, and just warning me, said, maybe you don't want to go down this road. And I said, well, what harm can it be? All I'm going to do is tell the truth. I'm not going to fabricate. I'm not going to lie about anything. I'm just telling the truth. How can you get into trouble telling the truth?
Mm-hmm.
Which is maybe a little naive, but that's what drove me. And I don't have any trouble sleeping at night because of that.
Right. Well, and going back to what we talked about earlier, you were not beholden to being employed by a large hospital corporation or these days a hedge fund, a private equity fund, or a large group practice where, the partners would have come down on you. And I think that was really important.
It was fortuitous.
That's a good way to put it, because I know Dr. Kirby told me one time that he was across the operating table from another surgeon one time who we both know, I won't mention names, who said, Randy, you better keep your mouth shut. Mm-hmm. And it doesn't mean that they're bad people, but so much was known, not just in the spine surgery community, not just in the medical community, but it was all over the local news at the time. And yet, the vast, vast, vast majority of doctors, nurses, hospital administrators, everybody was like, keep your mouth shut.
Right.
And so, why is that? What is the culture of medicine that makes it that way?
I don't know. I don't know if it's the culture of medicine. I think it's the culture.
Mm-hmm.
And because you mentioned it, I mean, you mentioned the hospital employees, same situation. I mean, they're not in medicine. They don't have, a lot of them don't even have licenses. They're trained surgical assistants. Nurses obviously have licenses and so on and so forth. But I'm thinking of one of the surgical assistants that was in there that was hesitant to speak up about what they've seen. And then you think about all the instances of poor surgical outcomes that Duntsch had in multiple facilities, and none of those people said anything.
Right.
In this case, though, in Dr. Duntsch's case, in the case that I took over, it was interesting that the anesthesiologist on the original procedure by Dr. Duntsch, which took 6 hours and lost 4 units of blood and was a disaster, according to the anesthesiologist, he wrote a formal letter to the hospital administrator, and that helped generate their investigation over the next 2 days that resulted in my being called in.
Right. Well, as an aside, we know that separate and apart from his horrific lack of any surgical technique, any awareness of basic anatomy, that his behavior during Mary Eford's surgery was crazy. And we know that a prior patient, Floella Brown, was dying upstairs in the ICU, and that he kept coming in and out of the OR. And so that alone, you would think, would alert the other people operating with him to say, hold on, something's wrong. And then, I didn't know this for, at the time, our civil cases were pending, but the prosecutor, Michelle Schuver, told me later that after the procedure, after Mary Eford's surgery, he puts his hands up like a touchdown, like,
yeah, just
awesome.
Just that he walked out of the room.
Yeah. So I don't want to just pound this point to death, but it is a problem that people don't feel comfortable speaking up. And I always compare it, I and many others compare it to the airline industry. They are encouraged to speak up. If they're, a maintenance worker and they see, well, wait a second, my screw count is off or whatever, if it means grounding a plane, it doesn't matter. They're rewarded for bringing safety concerns. But it seems like it's almost the opposite in medicine. You're encouraged to keep quiet.
Yeah. And it's a little bit different. I mean, when you're talking about the airline industry, you're both in, repair and service, you're talking about an inanimate fixed structure, I mean, like metallic machinery, that's replicated time and time again. And then when you're talking about working on humans, you're talking about everybody's different.
Yeah.
I mean, their muscle and soft tissues are all different. Their bones are all different. You say, well, if there's anything similar, it must be the bones. Well, there's really hard bones, there's really soft bones, and there's everything in between.
Yeah.
And they all all hold, have different tensile strengths that, have to be considered when you're deciding what kind of instrumentation to put in and how to put it in, et cetera, et cetera. So there are just so many variables, and so many variables on technique, on how you get there and how you get out. What do you cauterize, and when you cauterize, which is a very safe and effective technique, but it also can be it can lead to problems. It can lead to infection. It can lead to loss of function, et cetera, if not used appropriately. And so again, I'm just saying there's just so many variables in living tissues as opposed to inanimate tissues that it kind of obviates replicating that type of implementing that type of a surveillance system,
right,
between airline industry and in medicine. It just doesn't replicate.
right. I can see how, you don't want a surgical tech saying, well, I don't think the, fellowship trained surgeon cauterized that vessel appropriately. But, kind of using the airline example, if the co-pilot sees or smells alcohol on the pilot's breath, or sees the pilot going through the pre-flight checklist and is like, this guy has no idea what he's doing, he must be impaired or had a stroke, something's wrong, the co-pilot's not going to let the airplane go off the ground. Because for one thing, that's the co-pilot's life at stake as well. And so, I just think I see it in my practice all the time, where everybody's in the know except the poor patient. And the chatter, the nurses know, like, who are the problem doctors on the unit at the hospital, who they would never send a friend or family member to or whatever, but
Right.
patients don't know.
Yeah.
So,
and then it's still the difference, and I know what you're talking about. The information's there somewhere, and it's always easier to see it in retrospect than it is real time, or to anticipate it in the future. I mean, you don't go around being that suspicious. Most people don't.
right.
And then in your experience, obviously you get everything concentrated. I mean, they don't send you the okay cases. They send you the bad outcome cases. And so then you get to look through the retrospectoscope, and everything seems to line up. And you said, how'd you miss that?
Right.
But when people are whispering to each other and you're walking down the hall, you can't hear those whispers.
Right.
And unless you're suspicious.
Well, you know what else is, most of the time in medical malpractice cases, we get that perfectly dictated operative report, and we don't have a photo or a video, or another surgeon who actually opened the patient up to say, this cannot be the same thing. Oftentimes we just have a perfectly dictated operative report, and the primary person who was there to tell the story, the person who's on trial, to say everything went perfectly.
And that's interesting because, in some fields now, and particularly in orthopedics and sports injuries and so on and so forth, arthroscopically, they've been able to take videos of their procedures for decades now. And that's been very helpful. That's been very helpful in explaining situations to the patients. They don't have to explain it anymore. They can show them what the problem is. And when you have a bad outcome or an adverse outcome, you can say, well, yeah, this is why.
Right.
It's not anything I did or didn't do. It's just the circumstances that were there that you can now see. And then, of course, if there was a preventable adverse outcome, then we can see that too.
Right. And intraoperative fluoroscopic images, and I know some doctors will do those kind of proactively to say, let it hereinafter be known that I put the screw in the right location, and
Exactly.
here's the evidence. The question that I want to ask you is this: you're brought in to the Mary Eford case. When you see what you see, you decide that you have got to do something to stop him. And along the way, you began to learn that there were problems with the system. And what I'm wondering is, did you know beforehand that there were problems with the system, that there were problems with residency programs, passing people through or giving them recommendations when they shouldn't have, problems with the hospitals not conducting proper peer reviews, not reporting to the data bank, problems with the medical board not being proactive? Or were you kind of learning these things as you're going along?
Little bit of both. I came up through a training program. That's what we call a pyramid program, where there were 5 of us that started our first year in the program, and then by the 3rd year, there's only 2 that are left. And pyramid program was something in surgical training that existed from the very beginning, and it made some sense. It's kind of cruel in some ways, but it makes some sense in that you take somebody into a surgical program. Obviously, you're able to determine if they're intelligent enough to be in there and educated enough to that point to be in there. And you can evaluate their personality for the most part before getting into the program. You learn more as time goes on because it's normally a 5-year program. And you start to learn how people respond under stress and under fatigue, and in stress both within and within the hospital environment and outside the hospital environment, because life goes on.
Right.
But how it affects their ability to perform, et cetera, et cetera. Then obviously you evaluate how they're able to transpose their intelligence and their experience and their deductive reasoning into what they do with their hands. And most people can do that. Some people are much more excellent at it than others, but most people can do a very good job. But there are some people who can't and will never be able to do that. So it's made an issue in some training programs these days, the last 20 years or so. Well, you've already invested 2, 3, 4 years into your training program, and now they realize, well, you're really a marginal technician at best. What are we going to do with you? And sometimes if you can sit down and talk with those individuals, they'll say, yeah, you're right. I've tried my best. I just can't get any better at it. Do that. And they transition into something else. Others, you have to say, well, do we fire you or do we not fire you from the training program? And there's been a reluctance to fire people at that stage of the game. They still provide a benefit to society, but they also provide a risk to society. Getting into situations that the normal, average, above average, superior surgeon would be able to handle without much difficulty. They get into situations they can't do it. So what's right and what's not? But the fear or resistance to letting him go really comes down to the fear of being sued for wrongful termination. And it's been an issue that has presented itself multiple times and will continue to, because there's just no good way to evaluate whether somebody's going to be the right person to finish that program or not, unless you go through the program.
And, maybe it's naive of me to say this, but as it applies to you and in comparison to some of the other people involved in the residency program or hospital administrators or whatever, the moral courage and conviction to say, I don't want other people to get hurt. And doing the right thing is always the right thing. And I'm not going to go around on this earth saying, oh, I better not say that, or I better not do this. I might get sued. And that's what perturbs me is, where's the courage and conviction just to say, look, we went to medical school or we went into healthcare because we wanted to help patients. And, we've got an obligation here to patients.
Yeah. Yeah. And, that gets promulgated and reinforced throughout your life. I think it starts with your parents, probably. And it starts with all the people that have influenced you. What you find to be the best pathway in life and what you can live with. And fortunately, in my training program, as I got to that point in my life, all of that was just reinforced. If it's good for the patient, that's what you do. And my whole philosophy of my training and going into practice and being in situations like being appointed to the board of directors or medical executive committee or credentialing committees, whatever they were, was I always just said, well, whatever's good for the patient first is where we go. And our state medical boards, I think 49 out of 50 of the state medical boards in their creed or motto, they all state either initially or somewhere within that creed that patient safety is their number one priority.
Yeah.
And that's what they state. And they need to keep reading that motto.
That's exactly right.
And keep remembering that that's what they're there for.
Well, we need to clone more Dr. Robert Hendersons. We need more of you all. I tell my SMU law student class, if there was ever a modern day Dr. Marcus Welby, it's you. And 99% of the people who are listening to this podcast will say, who's Dr. Marcus Welby? But you and I know who he is. And so, again, thank you for your moral conviction, your moral courage. You saved lives in this case and in other cases. I appreciate you personally. We've continued to stay involved in our group, which we're going to talk about some more. No more doctor deaths. And so we're going to keep fighting.
Good. Looking forward to it.
Thanks so much for coming down.
You're very welcome.
All right.
Thanks.
I want to thank Dr. Henderson again for taking his time to come and talk with us. And I really intend to have him back to talk about many other topics that patients need to know about. So if you liked what you heard, please like and subscribe and come back for more episodes.